So,
Okay.
good evening, everyone, and thank you for joining us for our latest webinar from the East Sussex Eye Group. This webinar is being recorded and it will be available to watch again on our YouTube channel, the East Sussex Eye Group. There is one CET point available for today's lecture, and that's an interactive point, and that's if you're watching it live from the link when you're registered. And the CET point is available for optometrists and dispensing opticians. The lecture, as usual, will run for about 45 minutes with about 15 minutes of questions at the end. So at the bottom of your screen, there is a Q&A box. So if you have any questions during the webinar, please type them in there. And then at the end, I will then pose the questions to our guest speaker. Tonight's lecture is on how to do a good referral and referral pathways. So if some of the referral pathways will be specific to this area. So if you're watching from a different area, it's probably worth just checking your referral pathways, but I think the talk will be useful for everybody. So I'd like to welcome today's speaker, Mr. Kashif Qureshi. He's an ophthalmic consultant surgeon at East Sussex Healthcare Trust, specialising in the management of complex medical retina disorders. He performs intravitreal anti-VEGF injections, steroid implants, anterior and posterior segment laser treatments, as well as high volume cataract surgeries. For the past 2 years, he's been the clinical lead for East Sussex NHS Trust, and he's also a member of the Professional Standards Committee for the Royal College of Ophthalmologists. So I'd like to hand over to you now, Mr. Qureshi. Thank you very much.
Thanks, Ian. Okay, so I'll share my screen, and it's that. Share. Excellent. And how do I do it? Oh yeah, there it is. There we go. All right, so what I'm going to talk about tonight is how to write a good referral, and when to refer, and some of the pathways of referral in our area. I write this lecture very sensitively in the mind that I don't want to patronize you, because I know all of you here are excellent clinicians who do a great job every day. But it's fair to say that, you know, things are becoming more pressurized, and the communication between hospital services and the community could be better. And I'm sure it will be better in future as we're working on all sorts of IT solutions locally and nationally. But I think that understanding where we're coming from might help to enable the communication to be a little bit better. So Ian's very kindly given me the introduction. The one thing he didn't say is that I'm also the ICS clinical lead for ophthalmology in Sussex. Why that's relevant, not because I'm sort of bigging myself up, but because I am part of the group that are redesigning the pathways for ophthalmology across the whole of Sussex for the key conditions such as cataract, glaucoma, MR conditions, etc., etc. So I'm sort of integral in the role of how the referrals are going to be accepted from the community, and most importantly, how we go forward to work to provide more of the services in the community. So, as I've said, we've got increasing demand from patients, and this has got worse with COVID because patients are being directed more to community optometry, you know, as a first line of sight. A lot of patients are trying to stay away from hospitals during the waves of the pandemic and even afterwards. GPs are also aware that it's probably better, in fact, for patients to be seen by an optometrist rather than a GP who is completely clueless about eyes, whereas an optometrist is a trained professional who can deal with eyes. So we've got an increase in reliance on community optometry. And there is a sort of expectation nationally, both from the Royal College of Optometrists and the Royal College of Ophthalmologists and all the other big groups in the NHS, or that involve the NHS, NHS England, GERFT, all these other initiatives, get GERFT standing, meaning get it right first time, which they often don't, ironically. But there's an expectation that a lot of the work that is currently done in the hospitalized service will be done in the community, or will be done in shared care in the community, because the capacity in the hospitalized services, due to a variety of different reasons, but chronic underfunding, chronic staff shortages, etc., just cannot meet the rising demand. So in East Sussex, we are, over the next 10 years, we are looking at a 25% increase in demand for hospitalized services. So I'm in the midst of redesigning or transforming the way ophthalmology is delivered in the hospital, or the secondary care services. And we are very aware of the increasing demand that there is. Currently, we receive around 400 referrals every week, which we now receive by and large electronically, not all of them. And so consequently, we have to look at all 400 referrals, which are sent as attachments, often PDFs or Word documents that we have to download and read. So it takes time. So it's therefore important that the letters we get, both from the general practitioners, but also the optometrists, are quite succinct and highlight what the problem is that we need to look at, because often a consultant will be looking at many of these, whenever they've got a minute, usually in my lunch break, I'll burn through 30, 40 referrals. So it is important that the messages that you're trying to convey are quite clear. So the questions to ask yourself really is, why am I referring a patient? Who is my target? Is it a GP? Is it an ophthalmologist? And, this is relevant because quite often we get referrals, or we get letters that the GP clearly hasn't read. And it's simply saying, dear GP, I have found a small hemorrhage, outside the macula. This patient is elderly and has got signs of hypertensive retinopathy. Please, can you investigate them in a cardiovascular workup? Now, if it's as clear as that, you'd hope that the GP would act on it. But still, we get a lot of referrals like that, where it's clearly not for us. It's for the GP to sort a patient out, or to initiate investigations, and it doesn't happen. But very often, it's not communicated in language that is clear. Those sorts of referrals will be written like, there is a small hemorrhage at the macula. Please, can you examine this patient and refer appropriately, or something like that, which is not really that helpful, both for the GP or for the hospitalized service, because it's not really clarifying what it is that you want. Is it a referral to us? Most of your referrals are probably directed at us. And you need to have keep these four objectives in your head when you're writing a referral letter. And again, not wishing to sound patronizing about it, because I also have to refer patients all the time to different specialities, neurology in particular, rheumatology, sometimes respiratory medicine. And I have to stick by these rules myself. I have to think, what is my reason for my referral? What are the abnormal and unusual findings that I want to try and convey or present? What's the language that's appropriate for the recipient? So if I wrote to a respiratory physician and started talking about PVD or something like that, they would have no idea what I meant by PVD. They'd think peripheral vascular disease or something like that. So, it's worth, writing it, and they probably wouldn't even know what a posterior vitreous attachment was actually. So it's worth writing it in a language that they will understand. And that goes for the GP as well. Indicating a time frame or urgency. So this is a very important part of it as well, is that, you do need to indicate if you think something's urgent. And it is amazing how many times I've seen referrals that have not been indicated with any level of urgency, but actually were really quite urgent things that the GP has referred routinely, and at the bottom of a queue of 150 referrals. But fortunately, we've picked it up and brought it in early. So it is important, but also be realistic about your time frames. So seeing a patient with, for instance, an epiretinal membrane is not an emergency, and it does not need to be seen within 2 weeks or 4 weeks or even 6 weeks. You need to be considerate of whether this thing is going to change suddenly, or a patient with suspect glaucoma with pressures in the high 20s is not an urgent referral. That can be seen routinely. So as I've said, sort of consider, why am I referring this client? What's my concern? What's the cause of my concern? Who is it that needs to see this patient really? And when do I want this patient to be seen? And how best to refer? Because remembering what the pathways are locally, is extremely important, because referring, for instance, a patient with macular pathology via the GP is wrong, and will often result in delay that could cause unnecessary sight loss for the patient. How to help us, basically, or the GP for that matter. So the important thing to say is, to remember to do what you can do. You are a professional as an optometrist, and you're highly skilled. I work alongside optometrists both in the hospital setting, who are fantastic, and also in the community, who are also fantastic. And in my private practice, I work in optometry practices locally, alongside optometrists who are brilliant. So I am well aware that the optometrists around us are very capable, have a lot of clinical skill, a lot of clinical acumen, and can do a lot of the things that, frankly, we can do. But if you can do it and write it down and let us know what you found. So if a refraction is important. You might not think it's important, but it is important. I mean, there are obviously some types of patients where it is essential to include a refraction, although, believe it or not, it doesn't always come. So, for instance, pediatric patients, you would think that you would have a refraction, but quite often we see referrals sent with no refraction attached, or patients who are query keratoconus, no refraction attached. Patients for cataract surgery, no refraction attached. And that's singularly unhelpful, because it doesn't really help us explain to the patient what the refractive outcome might be. An examination of the eye, so any kind of ocular examination you can do is helpful, particularly if you can include the findings that are not normal. If you can do a visual field test in your practice, that's very helpful, particularly for conditions, sort of neuro conditions or glaucoma type conditions, and even things like ptosis, or things where you're talking about the field of vision being affected. A visual field test is very helpful. An OCT scan is also helpful, particularly for macular referrals. As you all know, in East Sussex, we have an email address. I will put that up later, where you can email your macular referrals to us. Now, a snapshot of an OCT scan is okay, it's helpful, it's better than nothing, it's nice to see. And if it's a snapshot through the area of pathology, that's particularly helpful. But if you can save your OCT as a video file and send us the file of the whole run, that's even more helpful, because that gives us the whole volumetric data, and that's fantastically useful for us. In future, one thing I would say is, if you are doing an OCT, just be mindful that if you're referring via the GP in particular, and you're sending a printout, they will scan the printout, and at that point it'll become unreadable because it won't be color, and then they'll email the printout to us, and it'll be completely unusable. So there's almost no point in printing it out, sending it to the GP, because it will almost become unusable in future. And the same goes with photographs as well. If you can email us the photograph or the OCT, that's much more helpful, along with the clinical history. What I was about to say is that what we are looking at the moment is an electronic system called EERS, or Enhanced Electronic Referral System, which optometrists will have access to, not just GPs. So you'll be able to refer all of your patients directly to the hospital's eye service without going via the general practitioner. And you'll be able to include all the digital data. So it will be a digital referral alongside this data that you're sending. And that's something that we're working on as we speak. Obviously, that's kind of the future and the way forward, really. But all of that data is incredibly helpful to us. As I said before, bullet point your findings. I know it's easy to write in continuous prose because that's kind of how you think, but it doesn't when you're in my position, a consultant sitting there and you've got a list of 150 referrals to look at. You really can't look at paragraphs of writing. You're trying to pick out the key salient features, and if you just bullet point them, that's all I'm interested in looking at. Angles narrow, pressure's a bit elevated, visual field looks a bit funny, please can you see query glaucoma? That's absolutely fine. But writing a long continuous prose paragraph doesn't really help anyone. Just to say to the people who are asking questions, I will answer the questions at the end of the talk, and we can, but please feel free to post your questions in the little question box. Write clearly. So if you're typing, great, because then your handwriting is not an issue. If you're handwriting, please write it legibly, because again, they get scanned and then they get emailed and so on and so forth. And if your writing is not great, I know I'm very much the pot calling the kettle black here because I'm a doctor, and by law I should not be able to write properly. But please write clearly, because it's very difficult to see, and that goes doubly so if you're sending in a refraction and you're handwriting the things, because sometimes it's difficult to make out whether it's a plus or a minus on the thing, and that can be quite important. As I said, be realistic in your time frames. So be aware of what's reasonable and what's not. And certainly in East Sussex, we don't mind if you ask us, we can tell you, well, that's actually a routine referral, or that's an urgent referral, etc., etc. Certainly on our group, our East Sussex Eye group that we share messages on, usually one of us is there to be able to provide answers if you're not sure. And as I say, use your clinical acumen. You clearly have it, and the optometrists I work alongside and see, and the referral that we receive, if for the most part, are from clearly intelligent people who know what's going on. Why is this not advancing? Yeah. So this is an example of a not realistic referral, quite a recent one actually. So patient came in complaining of intermittent bright vision loss episodes lasting 10 minutes, experienced 3 episodes in the last 6 months, the last one occurring a day before this referral. Slit lamp examination was unremarkable. Please can you see the patient as an emergency? And my question is, what for? What's the emergency here? So the patient's got episodes of vision loss which last 10 minutes and then recover. So, and it's quite a young patient, it's probably a migraine. Why is this an emergency? What is it that's telling us that this is an emergency? This one is a bit difficult to explain. Mrs. So-and-so attended for her eye test today, complaining of the inability to produce tears. This was noticed when her husband passed and she was not able to cry. There was no staining with fluorescein, examination unremarkable. Please can she be seen for further investigations? Many thanks. I'm not sure whether this was asking us to determine whether the patient had dry eyes, or whether they wanted us to determine whether the patient was a psychopath who couldn't feel any emotions when her husband died. But anyway, that's me being flippant. But it's not it's a strange referral. So emergency referrals. Now, there aren't many emergencies in ophthalmology, I'm, pleased to say, and it's a reason why many ophthalmologists go into ophthalmology, is so we don't have to deal with too many out of our emergencies, but they do happen from time to time. And these two email addresses are the emergency email addresses for both Conquest side and Eastbourne District General. Of course, just to confuse everything, the ophthalmology department on the Conquest side is no longer at Conquest, it's at Bexhill Hospital, but that's the email address. So emergencies such as angle closure glaucoma, orbital cellulitis, central retinal artery occlusion that's within 12 hours of duration, any temporal arteritis, and by this we're looking at sudden vision loss, transient visual problems, sudden onset of new cranial pathology, palsies, weight loss, scalp tenderness, night sweats, proximal myopathy, painful pulseless temporal artery, macular detachments, ocular trauma, particularly penetrating trauma, microbial keratitis, endophthalmitis, and of course papilledema. So, I mean, we'll talk about sort of urgent referrals, but the emergencies need to go by these email addresses. I would stick to what I've said before in terms of, writing a referral that's clear, concise. It contains all the salient information, and preferably as many bullet points as possible to illustrate what you're concerned about. So wet AMD, is an urgent referral rather than an emergency. We know that it's one of the biggest causes of sight loss in the UK, and generally it's less than 3 months history of vision loss, which is spontaneously reported distortion, onset of missing patches, blurred vision in the center. You want to check their best corrected visual acuity, including their near vision. And if you've got unexplained unilateral plus shift in the refractive error, that's always a suspicious feature. Obviously AMSA grid testing is extremely helpful, and examination of the patient, preferably dilated with a slit lamp or an indirect, will often show area of elevation and hemorrhage. I know that many of you in the community have OCTs and are picking these things up now, which is wonderful. And please, the ones that don't, consider strongly the business case for getting an OCT, because they're incredibly helpful, and can provide you with answers very quickly. So the NICE guidance with wet AMD, it's still the same. No treatment for patients if their vision is better than 6/12 or worse than 6/96. No treatment for patients who've got structural damage of their fovea, and if the lesion is less than or equal to 12 disc areas in dimension, they can have treatment. If there's evidence of recent presumed disease, they can have treatment, and pay particular attention if a drusen, hemorrhage, there's subretinal fluid or exudates at the macula. What do? Well, you refer via the rapid access pathway directly to the hospital, and the email address for this is as below, the one there for Bexhill and for Eastbourne. Do not refer via your GP or via the GP if you think this is wet macular degeneration. Even if you have a suspicion of it, don't, because the GPs will often sit on the referral letter and not process it and send it straight away. 1, 2, they'll often not understand and they'll send it routinely, and then it might not get seen for ages. If you've identified pathology that you really think is significant, then the best thing you can do is refer it to us directly, preferably via this email way, ASAP. You can send in a referral letter or one of the rapid access forms for macular disease, but if you can do that, and if you have got an OCT and you can send the images from the OCT, that will be wonderful. If the vision is worse than 6/96, then they can be routine, because we can't really treat those patients according to NICE. If they are referred urgently, then they're seen within 2 weeks, is our aspiration. The treatment is much the same at the moment. It's the mainstay are anti-VEGF injections. Probably the majority we give now, Eylea, Lucentis, we still give to some patients, but it tends not to be our first line of treatment. It's a bit of older medication. And then, of course, Avastin. So the Avastin story has modified a bit. NICE guidance has been updated. So vision better than 6/12 can benefit from treatment, but currently there's no licensed drug for this indication. So there was a judicial review a year or two ago that looked at using Avastin for wet macular degeneration in the NHS, and it was found that NHS organisations could offer Avastin instead of Lucentis or Eylea, because the cost was so much less and it would save money. But there is a problem with Avastin, which is that it's a logistical problem. One is that if you've got patients who've already been treated with Eylea or Lucentis, you can't just switch them all to Avastin because they've not consented to that treatment. And also it's not like for like, certainly with Eylea. Two, if you've got patients who are treatment naive, so that means that they've just been diagnosed, they've not had any injections, then what we would have to do as clinicians is offer them a choice of Eylea, Lucentis or Avastin. And it's very rare to find patients who are altruistic enough to say, yes, I want the cheaper drug because it will help save millions for the NHS. The vast majority of people will say, I want the expensive stuff that's got the biggest evidence base behind it and is the licensed medication for use. So, you know, despite Avastin being made available, most departments still don't really use it very much in the NHS. In the private sector, we use it because it's much cheaper than the other two medications. So it enables patients to be able to have affordable private care if they want. So that's where we are with Avastin. We can use it, but we don't use it because commissioning wise, it's tricky, and implementing it and logistically is a difficult headache at the moment. There is a new medicine which is called brolucizumab, or Beovu is its trade name, and trials have shown that around 50% of the patients can have this injection, and after 3 monthly injections may not need injections until every 3 months, so 12 weekly dosing, which sounds brilliant. I mean, that's Eylea at best is 8 weekly dosing, so 12 weekly extends it out even further, which sounds great. Problem with brolucizumab though is that they've got a very high percentage of patients who develop severe intraocular inflammation, which looks very much like endophthalmitis, but it isn't. It's like a very severe uveitis that can happen as a result of an injection into the eye. And the problem with it then is that the people who are using brolucizumab are changing their pathway, so the patients get seen face to face by a clinician at every single visit, whether they have an injection or not, and that's a real headache to implement. So it's something that it is available, it is NICE approved now. We could use it, but we don't use it in East Sussex because implementing it is tricky, because there is a significant amount of inflammation. 5% is quite high. There are other medicines coming which don't have apparently the same level of inflammation, and do offer 3 to 4 monthly dosing, one in particular called faricizumab, but we're waiting for that to become NICE approved and for key trials to present. Lastly, there's been more work done on implanting drug reservoirs into the eye. So vitreoretinal surgeons bury what looks like a sort of vase into the eye, and it can be accessed externally, and you can inject Lucentis into it, and it slowly releases it into the eye over a period of time. And it apparently works very well, but it is a rather interventional procedure that requires specialist surgical skills to fit. So it's not something that yet has taken off in any way, shape or form. My keyboard's not cooperating. Dry macular degeneration, it's not an urgent referral. or an emergency referral. It can convert to wet type disease, but the conversion rate is not necessarily high. If there is a significant drop in vision or a significant change in their clinical appearance, it's worth considering a referral. If you've done an OCT, you can send that to us. Generally, we see these people in our clinic once to explain the diagnosis to them and then discharge them back to your care and the community, and they're advised to return to us directly if they suddenly start to have symptoms. Currently, as you know, there isn't really a treatment for dry macular degeneration that's widely available, although there are treatments around, and one is the LX2RT nanopulse laser. And this patient, this is the before slide, this is the after slide, and as we can see, many of the drusen at the central macula have disappeared after one application of this laser treatment, and this is something I'm going to be able to offer imminently at Centre for Sight in East Grinstead, where I do a session in private practice. But otherwise, you would offer patients, advise them to use AREDS2 supplements to reduce the chance the disease would progress. As I say, a routine referral if you feel it's necessary. And why that's important, because if you've done an OCT, you've not found any fluid underneath the retina, you're confident that this is dry macular degeneration, then I don't see any reason why an optometrist like yourself that's with it in the community couldn't just tell the patient, you've got dry macular degeneration, this is what it is, these are the symptoms to look out for, this is an AMSLA grid, you don't need to be routinely monitored, or I will routinely monitor you every so often, but you don't need to be seen in the hospital at all. If you have an OCT that you can send to us, that's great. Certainly if you're monitoring these patients, then an OCT is vital. As I've mentioned about ERS, in future, we will be able to look at the full volumetric scan of these sorts of patients and be able to report on them virtually. Retinal vein occlusions. So this is an obstruction of the retinal vein system by a thrombus formation, which may involve the central, hemicentral or branch retinal veins. And it's usually because of the compression of the arteries, which become atherosclerotic, and occasionally due to inflammation, such as vasculitis. In the CRVO, it's a central retinal vein as it goes through the lamina cribrosa, causing edema of the disc and widespread hemorrhage and dilatation of the blood vessels in all four quadrants, whereas a branch retinal vein occlusion is a branch and a hemiretinal vein occlusion is half. And a retinal vein occlusion is an urgent referral. So I would say 1 week, maybe 2 weeks at the most, because these patients can lose vision quite suddenly, like wet macular degeneration. It is important that the patient be advised that they need to see their GP to make sure their blood pressure is checked, their glucose is checked for blood count, ESR, possibly even an ECG. I think if you are going to send the patient to their GP, do make sure you send a referral separately to the hospital, because as I said before, what you don't want is the GP to just sort of sit on the referral and not send it on. And the GP needs to arrange, bloods and tests that they think are relevant. So we treat retinal vein occlusions with anti-VEGF injections, sometimes Ozurdex, which is a steroid implant that we can inject into the eye. If they're very ischemic, we can do PRP laser, pararetinal photocoagulation, to destroy the peripheral retina, and that reduces the amount of vascular endothelial growth factor that's produced and reduces the drive for neovascular disease. In a BRVO, we tend to use anti-VEGF and Ozurdex. We still have a place for laser. Strictly speaking, NICE says that we should be using laser first and only using anti-VEGF and Ozurdex if patients are unsuitable or if it fails. But to be honest, most patients are unsuitable because their macular edema is right at the central foveal area, so we wouldn't laser that area. If they've got BRVO, they might need sectoral panretinal photocoagulation if they've got any signs of neovascular disease beginning. Flashes and floaters. This is something that comes frequently, and you know, what are we worrying about? Well, patients develop posterior vitreous detachments and vitreous separation. Now, you got to remember that a posterior vitreous detachment is a normal process of aging. So more than 50% of people over the age of 60 have a PVD. So we all know that the vitreous as adults, it degenerates and becomes a bag of sort of liquidy water filled with bits of connective tissue that float around in it. And eventually what happens is the posterior hyaloid separates from the retina. And what actually happens, in fact, is that the posterior hyaloid face that you can see, oops, sorry, I've gone back, I didn't mean to do that, which you can see here, it splits, and the liquid water that's inside there then peels the posterior hyaloid face off the retina and lifts it up. Okay, and you know, then eventually it peels off its point of attachment around the optic nerve head, and you get a posterior vitreous detachment and a vice ring that you can often see floating around, you know, vaguely circular shape in the vitreous. And you know, why we get excited about this is sometimes when the vitreous base is firmly adherent, it can, as it peels off, it can tug on the retina and tear a flap in it. And if the liquid gets in underneath the retina, it can then peel the retina off, and you can get a retinal detachment. When to refer these patients? So if there's a sudden new onset of floaters, and there are pigmented cells in the anterior vitreous, and even in the posterior vitreous, of course, if you see vitreous, pre-retinal or retinal hemorrhage, if you can see a retinal tear, if you've got a lattice or round hole, but with new symptoms of floaters and flashes, then refer urgently, ideally the same day, but it can wait till the next day. Now, I put try not to game the system. So where this is because now with lots of areas have got mechs around, and optometrists are seeing a lot of these patients in the community. And there are pathways in many parts of the country where flashes and floaters are really primarily seen by optometrists, and we're only expecting hospital referrals if there are signs of a tear or suspicion of a tear. But if you as a referrer keep putting Schaefer positive, and then they keep coming to the hospital, and we find that there are no cells in the vitreous, you know, it's not a good look. You know, you need to look carefully. And if there are cells, there are cells. So there either are or there aren't. And if there aren't, and you haven't found a tear, and you haven't found any evidence of, you know, a hemorrhage or anything like that, then you don't need to see the patient again. But you can give them appropriate advice and tell them that their risk of developing a retinal tear or a detachment is slightly increased for a period of 6 weeks following their initial floaters. If the floaters change, or the flashes of light change, or the bits missing start appearing in the vision, then please report those symptoms to you or us straight away. Okay, and if they, you know, but if they do have a tear or something like that, you can see quite nicely in this photograph here, then yes, refer them to the hospital, and we can do laser around this hole to sort of seal it so that it doesn't progress. Pigmented retinal lesions, this is also something that's quite commonplace. So choroidal nevi generally are benign melanocytic lesions which are symptomless and found incidentally. Very occasionally they're associated with cystoid macular edema and SRF and neovascularization, but that's very rare. But what you should remain or keep in your head is that distinguishing features from a melanoma is that the margins are usually fairly clearly defined. It's flat, most importantly. It's stable in its size, so it's not increasing. Overlying drusen, controversial really, because they can be and they might not be, but overlying drusen generally mean it's been there for a while. RPE atrophy, hyperplasia or fibrous metaplasia. So it can get slightly bigger, slightly more fibrous or hyperplastic. These are routine referrals. They're not urgent referrals or emergency referrals. If you see a lesion that is suspicious, what you're looking for, so melanomas in particular, which are urgent referrals and should be sent, within 2 weeks or seen within 2 weeks, have indiscrete margins, generally in irregular configuration. Often there's overlying subretinal fluid. Sometimes, but quite often, there is orange pigment and elevated edges. And they grow, over 1 or 2 years in suspicious, features of activity. The rate of transformation from a benign lesion to malignant is incredibly small. It's sort of 1 in 8,845 cases. I'm sure Mr. Kashani went through this in his brilliant talk before, but the things to look for a melanoma are thickness greater than 2 millimeters, fluid, symptoms. So if they start getting any visual symptoms from it, orange pigment, margin less than 3 millimeters from the optic disc, ultrasound hollowness, is it solid or flat, absence of a halo, circular band of depigmentation, and the absence of drusen. So if a lesion you see has no risk factors, the chance of growth is about 3% if it's already slightly suspicious. If it's got one risk factor up here, then about 38% risk of growth. 3 or more risk factors, about a 50% chance of growth. When you are suspicious of a melanoma, then obviously those are urgent. Chirpies are round, well circumscribed, pigmented lesions in the retina with depigmented areas within the lesion often. If you've got multiple, then this might be what we call bear track lesions, which can be associated with familial adenomatous polyposis and Gardner syndrome, but actually it's quite rare. Very often you get bear track lesions without it. More defined edge of lesion, so you can see a very distinct edge to the lesion. It's much darker and more heavily pigmented than a nevus. And a chirpy gives an absolute scotoma, whereas a nevus doesn't affect the visual field at all. And again, these are routine referrals. Peripheral retinal degenerations. I love this picture because if this was one patient, it would be the unluckiest patient in the history of medicine, basically, to have every single thing that you can see on it possible. But you can often get senile retinoschisis in about 2 to 4% of patients. Retinal-vitreal degeneration, so white without pressure, retinal lattice changes, snail track lesions, glistening white dots in the young and myopic at the equator, with early stage lattice, white without pressure. Chorioretinal degeneration, so sometimes you can get paving stone lesions and punched out areas of atrophy, often bilateral. If they're asymptomatic, then I wouldn't worry too much about it. But if they're symptomatic of funny visual symptoms, then you might want to think about whether this represents a multifocal choroiditis. And these are all routine referrals unless there are suspicious symptoms that you're concerned about. Glaucoma. So moving into glaucoma, blimey, I really better motor on a bit. So NICE guidance was updated in 2017. Patients need to have central visual field assessment with standard automated perimetry, optic nerve assessment using a slit lamp and OCT if available. But as I've highlighted, do not refer patients based on an OCT alone. It will get rejected. The referral will get rejected because an OCT is a very poor indicator of whether there is a pathology there, because it depends on how you measure it. It depends where the measurements were taken from or the machine that you're using. Pressures need to be checked, preferably using Goldman, but there are some non-contact tonometers that are now becoming more and more accurate. Peripheral anterior chamber configuration and depth assessment using gonioscopy if you can, or Van Herrick. And trying not to re-refer patients that we discharge from the hospital unless their situation has changed significantly. So this referral, I think we received actually very recently. So Mr. So-and-so attended for a routine eye test, presented with repeatable asymmetrical IOP readings, 22, 15, presumably this was with non-contact. corrected because the corneas are quite thick. Please could you refer Mr. So-and-so for suspect ocular hypertension? So, you know, what are my comments? Well, it's non-contact tonometry. So how accurate are those readings? They might not be accurate. They might be accurate. It's difficult to say. But, you know, even if they are asymmetrical, you know, they're not pathological. The optometrist in this case brilliantly has measured the corneal thickness and found it to be thick. So the question is answered. 22 millimeters of mercury is because the cornea is a bit thick. So there's no actual problem here at all. It's not ocular hypertension because the pressures aren't actually high. And there's no evidence given about what the optic nerve looks like or whether a visual field test has been done. So these are the sorts of things that, you know, they're not that helpful, but they're actually, interestingly, there are things that you could probably sort out in practice without involving us at all and making the patient, you know, have to have attend another appointment. What's this? Is this enough? Mrs. So-and-so came for a routine eye examination. Repeatable pressure check shows intraocular pressures are unequal. Okay. I would greatly appreciate if you can routinely refer ophthalmologists for further investigation and management. Now, I know that there is some evidence that if patients have got asymmetrical pressures, you know, you can statistically be slightly more likely to develop glaucoma than the next person, but these pressures are not high. They're both within normal limits. And the disc looks normal. I mean, moderate cupping it doesn't make any sense because the cup disc ratio is 0.35, so it's not cupped unless it's 0.6. So it's a healthy optic disc. Visual fields are normal. So, you know, my suggestion would be recheck the pressures on a different time, just on a different day, to see whether there's any, you know, persistent asymmetry, or better still, do it with Goldman applanation tonometry to get a more accurate reading. Swollen optic discs. So I know there's a huge amount of fear in optometry, understandably, about swollen optic discs because of the Honey Rose case. But remember, Honey Rose got sent down because she didn't look at the pictures, and she said she did. You know, so the kid did have very swollen discs, and she didn't examine him, and she took photographs, then didn't look at them, and that's why she got into so much trouble. The sentence was completely unjustified, of course, but it does now therefore petrify everyone about missing a swollen optic disc. Again, remember what you can do and what you can test and what the optic nerve does. So the optic nerve looks, you know, is you can test the visual acuity, color vision, peripheral vision, and an afferent pupillary defect. And all of those things you can do in the community. So, you know, remember, if you see a patient, the visual acuity is slightly reduced, it might be optic nerve, whereas if it's macular, it's very significantly reduced. Color vision, optic nerves tend to get affected early, whereas the macular it's late or never. Visual fields, you get negative scotomas in an optic nerve lesion or a positive scotoma or distortion in a macular lesion. And an afferent pupillary defect is positive in a swollen optic disc, but negative in a macula. And, you know, the only contradiction to that is if the patient has bilateral symmetrical disease. So assessing the optic nerve head, are the discs blurred? Are the margins of the optic disc blurred or not? If it is, how much blurring and where? Are any of the blood vessels obscured? Are there any cotton wool spots to suggest ischemia or any hemorrhages? Is there a cup there, or is it obliterated? What does it look like compared to the other eye? Are there any spontaneous venous pulsations? Now, 20% of patients who are healthy don't have spontaneous venous pulsations, but generally, if patients have spontaneous venous pulsations, it's a reasonably good sign that they haven't got raised intracranial pressure. What is the refractive error? What are the patients presenting with? I mean, what's the problem? If they've not got any problems at all, or are they complaining of transient visual obscurations where the vision suddenly disappears for a few seconds and then comes back? Very often, these patients have pseudoswelling, so things like optic nerve drusen, which are calcium deposits that are buried and often seen on autofluorescence imaging. If any of you guys have got it in the community, it's a brilliant tool to be able to show autofluorescence imaging and showing buried drusen. Often patients have got quite crowded discs, so small discs with a ratio of 0.2 or less, tilted discs in high myopes, which can be quite difficult to interpret, look a bit swollen sometimes and elevated. OCT features of optic nerve swelling. So those of you who've got OCTs, you would be worried about optic nerve swelling if you've got increased thickness of the retinal nerve fiber layer, so the double hump pattern that you see. But you've got to be really careful that the centration around the optic nerve head is carefully centered and properly put there. I mean, if you've got a brilliant package like the Heidelberg that's got the glaucoma premium, that tends to measure it based on where the fovea is, and then it measures it very, very cleverly. So it's very almost dead center. But if you're manually doing it, trying to center it, you've really got to be careful where the nerve fiber layer is, particularly if it's a funny tilted disc. Blurred optic disc margins. So generally it starts nasally and then goes superiorly, inferiorly, and at last temporally. Assessment of the disc margin and the retinal angle. So true swelling, the angle is wide and raised, so the optic nerve head slopes into the peripapillary retina, whereas a pseudo swelling angle is much steeper and the raised nerve falls into a flat peripapillary area. Sometimes you can get pockets of fluid at the optic nerve margins, and sometimes with the OCT you get obscurations of the blood vessels on the actual cut. So they get covered by swollen nerve fibers from small vessels to large vessels. Differentials to think about are inflammatory, so optic neuritis, demyelination, sarcoid, lupus, atypical optic neuritis. Infectious, such as syphilis, sinus spread, vascular diseases, non-arteritic ischemic optic neuropathy or arteritic, diabetic papillopathy, compressive thyroid orbitopathy, optic nerve meningiomas, gliomas, infiltrative such as lymphomas or traumatic. If a bilateral disc swelling, can often be idiopathic, but what we worry about is if it's secondary related to things like brain tumors, trauma, venous thrombosis, renal failure, or certain medications. So this is where taking a medical history is important. Vitamin A, tetracycline, certain contraceptive type of medications, and lithium are known to cause disc swelling in patients. So it's worth asking if you see a patient with a swollen optic disc and including that in your letter to us. I put this in. It's the Friesen papilledema grading. I'm not going to go through it in detail, but I'm sure we're recording this and it will be available online, so you'll be able to have a look at it and look at the actual grading of papilledema categorically. So the diagnostic criteria for idiopathic intracranial hypertension, which often the majority of these patients have, is they need to have papilledema, a normal neurological examination, except perhaps for 4th, 6th, or 8th nerve palsies, a normal brain scan, but you can sometimes see a distended optic nerve sheath, a narrowing of the transverse sinuses, empty cella, slit-like ventricles, or a flattening of the posterior globe, and the CSF pressure is raised more than 25 centimeters of water. I know that that's not relevant specifically for the optometrist, but out of interest, I thought I'd include that. That's more for us when they come into the hospital. Pupils. So an AD's pupil, a very common denervation of the postganglionic supply, affects young people unilaterally in about 80%. The pupil is generally quite large and regular, but when you look at it carefully on the slit lamp, it has these sort of sluggish vermiform movements. It responds slowly to near and redilates slowly. It's generally long-standing, and pupil might become small eventually. If you did examine them medically, you can often find patients who've got reduced tendon reflexes. If you want to test it, if you can get pilocarpine and dilute it down to 0.125%, it causes constriction from hypersensitivity due to denervation. Horner syndrome, it's an oculosympathetic paresis, so it's there's interruption of the sympathetic nerve supply to the eye. You get meiosis, partial ptosis, and anhidrosis, so you can see that here. And the sympathetic nerves from the spinal cord in the chest ascend to the face, and they can get affected at various places. It can be caused by various things, such as this list, but obviously we worry about thoracic tumors, thoracic aneurysms, and brain tumors, encephalitis in particular. You know, postganglionic, they generally get no anhidrosis, but they can get cluster headaches, carotid artery dissections, and these are the ones that you can test with apoclonidine, which cause an increased mydriasis due to hypersensitivity. I don't know if anyone's got access to hydroxyamphetamine anymore, but you could use that to determine whether it's pre or postganglionic, but I don't think that's relevant now. If you're assessing an isocoria, you know, test the patient's pupils in different lighting settings, and it should be more than a 2 millimeter difference. In a dark room, if the pupil size difference persists in light or dark, it's often physiological. Unilateral physiological Horner's, uveitis, long-standing ADs, or pharmacological, and if it's bilateral, it might be senile meiosis, pharmacological, Argyll-Robertson's, or spasms of knee accommodation, and leprosy if you're really unlucky. Headaches, periocular pain due to trigeminal nerve involvement of branches 1 to 3. Take a good history. You know, is there any loss of vision? Is there any diplopia? Is there any new onset sort of cranial nerve type problems? Any redness, photophobia, jaw claudication, any systemic features like night sweats, weight loss, loss of appetite? Examine the patient carefully, check their vision, check their anterior and posterior segment, check for ptosis, edema, pupillary reactions, and fundoscopy. Primary headaches, migraines, you know, often with a visual aura, about 10 to 35%, often without an aura, more than 50% of patients, and they get pain and nausea and light sensitivity. Cluster headaches, so it's surprisingly common, actually. They get pain in and around one eye, and autonomic symptoms such as a watery eye and sometimes a ptosis. A tension headache, which probably a lot of people have had, where they feel like a band is squeezing around their head. And sinus headaches tend to be behind the eyes or the forehead or the cheekbones. Secondary headaches, which are related to other conditions, so ocular disease such as dry eyes, uveitis, raised pressure or accommodative spasm, orbital diseases such as optic neuritis and inflammatory disease. The one we worry about, of course, is GCA or giant cell arteritis, vascular diseases, you know, and those are where taking a history and examining the patient carefully is important. Ocular ischemic syndrome, it tends to, they will get a headache when standing up or sustained exposure to light. Intracranial disease, high intracranial pressure, they tend to get a headache, pain in their neck, the shoulders and upper back, and it's worse on coughing, straining. They sometimes get pulsatile tinnitus, which is ringing in their ears. And as I said before, transient visual obscuration. So the vision disappears like this for a few seconds and then it comes back. Sometimes double vision as well. And I've rushed through that last bit, but thank you for your attention. So I will see that there are some questions. So I'll try and burn through that. I'll try not to keep you all too late because I know it's nearly 9 o'clock. You mentioned that ERS is only for Sussex region, or is that planned for other regions too? Yes, it is planned for other regions. So I know in the southeast that Medway, Kent and Medway are implementing ERS in the same way that we are. They're a little bit further ahead, I think, than we are. I think Buckinghamshire, Oxford and Berkshire Trust are implementing ERS in the southeast. And I think a lot of other places are watching to see what happens, how it's implemented. and then be able to take it forward. It's not without its problems. Believe me, I've been a bit frustrated by the whole process with it, and I don't think it will solve our problems between primary care and secondary, in the hospital and the community. But it's better than what we have currently, which is nothing. So I never look a gift horse in the mouth, and hopefully it will come to something. It would be amazing to have a handy A4 crib sheet on referral. Is there anyone on this group who has one that could share? Thanks. There you go, Ian.
This is from the West Sussex LOC, and then the East Sussex LOC produced it, but this is from January 2010, so it might be out of date a bit. But I thought if I could show you this, Cash, and have a look at it,
yep.
maybe I could speak to Dimple at the LOC and see if we can get an updated one available to members.
Absolutely. Very happy. At what stage of the disease can I recommend RSG supplements to my patients? Are there any systemic conditions I need to take today? How long and often can the patients take these supplements? What kind of dietary advice can my patient recommend these supplements? Right, good question. So the AREDS2 study showed benefit if patients had intermediate uveitis, intermediate macular degeneration. Their reduction of risk was, it reduced the chances of developing advanced disease by up to 25%. Okay, so if they've got early disease, it probably won't make any difference whether they take AREDS2 supplements or not. It's not going to harm the patient to take the AREDS2 supplements, but the evidence suggests that the evidence base suggests it probably doesn't make any difference. And in those patients who've got early disease, you could just advise them to have a diet which is rich in fresh fruits and vegetables, particularly leafy green vegetables like kale, spinach, and then things like yellow peppers. But a good diet. Certainly none of them, you should advise all of them not to smoke, because smoking is terrible for this and it makes it much worse. Systemic conditions need consideration. In the past, these supplements contain beta carotene, and if patients were smokers, beta carotene promoted certain types of lung cancer. But I think most of the supplements don't have beta carotene in them anymore, so I don't think that is the case. I think what I would probably advise is if the patient's got any liver issues in particular, they probably need to discuss with their GP before they start using any supplements, additional supplements, that it's safe for them to use it. Right. With an RVO, do we refer to GP2 for blood workup, or will this be arranged by ophthalmology? Strictly speaking, we ophthalmologists would do that. Often it doesn't always happen for one reason or another, particularly at Bexhill, because we don't have access to regular blood taking facilities. But we can often give the patients a form to go and take to phlebotomy at Conquest, and they can get it done. But what the GP, why it is useful for the GP to do it is because they're often better at interpreting, particularly the cholesterol. And if there's a high cholesterol, we're not going to start the patient as an ophthalmologist on a statin. That's going to be up to the GP, and they need to have a conversation with the patient. So if the GPs are aware that bloods have been done, they're generally going to be more aware if they've requested it. But yes, an ophthalmologist can do it and often does do it, but not always. If macular off retinal detachment, what is the urgency of referral? Less urgent. I mean, I would still contact the ophthalmologist as soon as you can. But what I would suggest is be prepared for the ophthalmologist, for the VR service to say, we won't see this patient until next week or something like that. If a patient has wet macular degeneration confirmed with an OCT, but VA is better than 6/12, we still refer via wet pathway. Yes, I probably would, actually. I would. Because it's possible that by the time we see them, the vision might drop, is one thing to say. Second thing is, even if the vision isn't as good, the patient can be seen. I know it's not us profiteering, but they can be given access to having private treatment from ophthalmologists who do private work. And actually denying the patient access to that is not doing them any favors. So yes, I definitely would refer them urgently, even if the vision is better than 6/12. Hang on. My thing just. Can a retinal tear occur post PVD if none was visible when PVD was diagnosed after dilated fundus examination? No, generally not. If you examine them properly, then probably not. But remember, even if you dilate a patient, you're only looking at 90% of the retina. There's about 10% you can't see, and that's where indentation comes in handy, or a 3-mirror lens to be able to look at the peripheral, very, very far peripheral retina. So it might be that the patient may have had a tear more peripheral than you could see, and therefore a detachment occurred. But if there's no traction on the retina, then the patient should not get a retinal detachment afterwards. Are there any features of dry AMD that might indicate risk of conversion to wet AMD? Definitely, if they've got confluent soft drusen, that tends to be a big risk factor. If they've got a very high PED, pigment epithelial detachment, so a big tall PED, they tend to be more likely to develop wet macular degeneration. But it doesn't mean that I would then refer the patient, because we're still not going to do anything. I mean, refer them urgently, because we're still not going to do anything about that. If pressures are asymmetrical with a bigger difference of 4 millimeters mercury and distance fields are normal, is it okay to monitor 12 months rather than refer? Yeah, I think absolutely, because by definition, there's nothing wrong with the patient. The optic nerve is healthy. The visual function is healthy. Yeah, the pressures are asymmetrical, but that might be because how they're being measured. So a lot of questions seem to be disappearing. If we,
I'm deleting them as you're reading that.
All right, thanks. I was like, oh my god. If pressures are asymmetrical, yeah, we've done that one. Okay. If we suspect new HORNER'S, should that be an urgent referral? Yes, I think it should be an urgent referral. We would probably see that within a week or two, because that patient needs an MRI scan of their brain and chest as well. What does LX2RT nanopulse laser do? Who could benefit from it? So what it does is it's not a new thing, funnily enough. It's been around since 2013, and there are peer-reviewed data for this. So it's a nanopulse, it's a frequency doubled YAG that delivers a nanopulse of energy. So it's a thousandth of the amount of energy of regular lasers. And what it's supposed to do is stimulate the retinal pigment epithelial cells to induce a wound healing reaction. And that then, that wound healing reaction stimulates the retina to then absorb the drusen that has accumulated. And what we think is it then may set the clock back on the disease. So a patient's got dry macular degeneration, you do it, it's successful, it clears away a lot of the drusen, and it means that the clock is set back. So that it still may progress, but it may buy them another number of years. Now, quantifying that is very, very difficult. No one's done enough of it to be able to know. But what we do know is that it can work. And that picture that I showed you is a patient I treated myself back in 2017. It was quite extraordinary, really. The drusen seemed to sort of disappear in the center on one application of 12 shots of this very, very gentle laser. So it's not a cure, and I would emphasize it's not a cure, and no one would ever sell it as that, but it might enable people who've got intermediate or medium to intermediate to advanced disease to prevent it from getting into atrophy and end stage disease, which is could be really beneficial for people, giving them some more years of good sight. The one thing that is not suitable for, though, is if patients have got reticular pseudodrusen. And that's difficult to pick up in the community, and that would be probably an ophthalmologist would have to determine whether they're reticular pseudodrusen or whether they're standard drusen, but it won't work in reticular pseudodrusen patients.
I have a question for you.
Yes, hello.
You mentioned about working with fantastic optometrists in the hospital. I'm going to take you referring to my colleagues on that one. But you also mentioned about emergency referrals and using the email address. At weekends, is that email constantly monitored, or do you know?
That's a good question. No, it probably isn't. But you know, the on-call ophthalmology is available via switchboard on the weekend. So you can phone up the hospital switchboard and ask them to put you through to the eye doctor on call, and whichever poor sod is on will have to answer and can speak to you. And actually, you know, often that's actually much better, because you can tell them what you're worried about and they can talk to you, and sometimes they can actually advise you what to do with a patient and avoid them even having to come in. So yes, so on the weekend, out of hours, do phone up and speak to the on-call doctor. And generally they're quite nice. I mean, if they don't answer, leave them a message or something, because sometimes they're in A&E and they're a bit busy, but they are it's in their interest to talk to you, because then they may be able to avoid seeing the patient that night, or they can say to you, well, actually bring the patient tomorrow, it'd be better to see it tomorrow. I work in Tunbridge Wells. In some cases, we have patients who live in East Sussex but are registered with GPs in Kent. In those cases, do we refer via the East Sussex pathways or via West Kent? Well, I would always refer to East Sussex. You know, you don't want to refer to those losers in West Kent. No, I'm only joking. I mean, it depends on what the patients want. I mean, in terms of access to hospital eye service, I would say, I know I'm biased, but I think East Sussex were much more accessible than Maidstone and Tunbridge Wells, who are much less accessible than we are, and they have a much slower response rate. But what you are blessed with in West Kent is a very good network of optometrists that run the APCOS system, who see primary care ophthalmology things in the community. And I know this because I do sessions for a APCOS provider and see some of the patients with them. So, you know, they are catered for quite well in that regard. So, you know, it's up to you. But in East Sussex, we would be very, very happy to see patients that are, you know, from anywhere really. Hi, we're Tunbridge Wells based too. Oh, hello, Aileen. I've seen many of your referrals. My understanding is it goes to which county's patient's GP is in, but more happy to be stand corrected. I think that you're probably right. And Elian says refer to Ken. No, Elian, no. No, you're probably right. You can, you know, as I said, you're lucky, you know, it's a bit of double-edged sword in Kent. You've got the community aspect is really good and really tight in Kent with APCOS, and actually they're very accessible, and they've got a good amount of appointments available, and they will often see things, and they've got a very high level of expertise and can see things and sort them out. And some of them, like Elian, I'll never hear anything back. What, from APCOS or from me? I hope not. Anyway, but if you refer to APCOS, they will be seen by them and in a timely fashion and sorted out quite well. But yeah, East Sussex, we're happy, certainly happy to see patients particularly if the patients live in East Sussex, in Crowborough or areas which are, you know, adjacent to that side of Kent. So, you know, you're kind of lucky in that regard, because you've got a range of places. Oh, thank you. Gold stars for APCOS in you. Yeah. You know, you're lucky because you've got access to those sort of avenues for referral. But what I would say is, in East Sussex, if you are in sort of Crowborough or Uckfield or somewhere like that, or somewhere adjacent to, or even if you're in Tunbridge Wells, no one in East Sussex is going to say, why are you referring to us? You know, if you think the patient's got an urgent problem and you're really worried and you can't get through to Maidstone and Tunbridge Wells, and God knows I've tried some myself, and that can be really difficult. You know, we would be, you know, we're not too far away, and we may well be able to help you.
Brilliant. Thank you very much. There's one last question.
That's all right. Hang on, I have to turn off the chat. Hi, is it worth mentioning the esussex.loc.org.uk and other LOC websites for local referral pathways and email addresses. Yes, sorry, I stand corrected. Liz is absolutely right. So there is that email address that Liz has put up. It's www.esussexloc.org.uk. And there are local referral pathways and email addresses on the website. So just to remind yourself of that. And look at the website, which might give you a bit more information as well. But hopefully the talk was helpful. As I said, I think my summary to you is just to consider your referrals. Write what you can write, but put it in a succinct format, in bullet forms if you can, bullet points, rather than continuous prose, which is quite difficult for anyone to read.
Cool.
So yeah, I mean, we can all help each other out, and I think as we go forward in the future, we're going to be doing more and more work together as a group. With me being in the hospital, you guys being in the community, seeing many of my patients, this is the way forward. So I think if we can get communication levels better, then that will help us all. Alien has come back with a comment. Comes down to funding. CCG have already paid MTW to see all ophthalmology. The patient can choose to go to anywhere in the county, but if a GP or optom keep referring cross area, then CCG will not be happy to pay extra for something they have already paid MTW for. But yes, patients can choose to go anywhere. I mean, yes, you are of course right, Alien. But I think the only thing I would say to that is if a patient's got a problem that's urgent, and you're not, it really is urgent, and they're not being given access, locally, then they need to. An optometrist, you would worry for your patient, and you want them to get sorted out. Now, I think that's not likely to happen because APCOS in West Kent is very good, and I think that you're likely to get seen pretty quickly by someone in one of the various practices that offer it. So that's an avenue. The issue, I suppose, is if you've got a patient that does really need something that an ophthalmologist only can deliver, and you recognize that in practice, and it's probably not, that it's going to go from APCOS to the hospital, whether you feel confident that Maidstone is going to see the patient quickly enough. I don't know, because I don't work in Maidstone and Tunbridge Wells, so I can't tell you what they're like. All I can say is that in East Sussex, we're quite accessible in that regard. If patients have really got genuine urgent problems, we have got huge capacity issues, but we really try hard to see everyone that needs to be seen urgently. But it helps if the referrals we're receiving enable us to triage what is urgent, and that's what I'm trying to get at. And you can help us with that by making sure that the referrals we receive enable us to triage what is actually urgent and what isn't urgent. Anyway, I'm banging on, so I'll stop now.
Well, thank you very much, Mr. Qureshi, for that. That's been a fantastic talk, again. So thank you very much for giving up your time for us. Just for everyone, I will put the CET up this weekend, hopefully, and it is being recorded, so I will put it on the YouTube channel early next week, I think. I'll aim for. But thank you very much once again, Mr. Qureshi, and thank you everyone for watching.
Thank you, everyone.
End it there. Take care, everyone. Stay safe. And there are going to be some more webinars in the new year, but this is our last webinar for this year. But keep looking on the group, and I'll post when the next webinar will be up. Take care.
Cheers. Bye.